It's easy to think smoking is fading away everywhere, but the fact is, over 1 billion people globally still smoke. And a
Wow,
lot of that is concentrated in lower and middle income countries.
that's a really stark number.
It is, and okay, let's unpack this because that context really sets the scene for our deep dive today. We're looking at a rare, but, well, pretty serious condition linked directly to tobacco. Thromboangiitis Obliterans, TAO. You might know it as Buerger's disease.
Right, Buerger's disease. And what's really striking about TAO, unlike, a lot of smoking-related diseases that take years to show up, this one can hit people when they're relatively young.
Young, exactly, and the impact, especially on their limbs, can be just devastating.
Absolutely.
So for this deep dive, we've gathered a ton of medical literature to really get under the skin of TAO, our mission today, to nail down the essentials. What is TAO? Who gets it? What do the sources say about causes? How do doctors diagnose it? And critically, what treatments are out there, especially focusing on why quitting smoking is just non-negotiable. Ready.
Let's do it. So at its core, Thromboangiitis Obliterans, TAO, is this rare inflammatory disease. It affects the small and medium-sized arteries and veins. Okay. Mostly in the arms and legs, kind of below the knee and elbow, what we call infrapopliteal and infrabrachial.
And the key thing is it's not atherosclerosis, right? Not that typical plaque buildup.
Exactly. That's crucial. It's non-atherosclerotic. Instead, it's inflammatory and occlusive. The vessels get blocked by inflammation and clots.
Right. And it has a bit of history, this condition. Our sources mention Buerger's disease, obviously named after Leo Buerger, who really pinpointed it back in 1908. But also sometimes von Winowerter-Buerger syndrome, recognizing Felix von Winowerter even earlier, like 1879.
That's right. Von Winowerter's description is now seen as probably the first published account of what we call critical limb ischemia, basically.
Right.
Really severe lack of blood flow.
Wow. Way back then.
Yeah. But early on, these cases often got lumped in with other things like hardening of the arteries, arteriosclerosis, or even frostbite. They just didn't have the tools or understanding to separate them out clearly.
Until Buerger came along.
Precisely. Leo Buerger saw this pattern, this progressive blockage, especially in younger immigrants needing amputations, and he specifically called it Thromboangiitis Obliterans to distinguish it.
Distinguish it from the more common age-related stuff.
Exactly. And he also made that vital link with migrating thrombophlebitis, that vein inflammation that seems to, well, jump around.
Yeah.
His big monograph in 1924 really laid the groundwork.
Okay, here's something I found really fascinating from the sources. Between the 1930s and the 60s, there was actually a lot of doubt about whether TAO was even a real separate thing.
Yeah, that's true. A period of skepticism.
But thankfully, by the early 60s, experts basically confirmed, no, wait, this is distinct, and now it's recognized, right, as a specific type of vasculitis vessel inflammation with its own characteristics.
Absolutely. Its own clinical picture, its own progression, how it looks under the microscope. It really shows how medical understanding evolves, doesn't it? What seems clear can be questioned and refined.
Definitely. Okay, so who actually gets TAO? Our sources point pretty strongly to it historically being a young man's disease, usually showing up before age 45 or 50.
That was definitely the historical trend, predominantly young men. But that picture is shifting.
How so?
Well, largely because smoking rates among women have increased globally. So we're seeing a definite rise in the number of women being diagnosed with TAO. It's still more common in men, but certainly not exclusive to them anymore.
And geographically, it's not spread evenly across the globe, is it?
Not at all. The prevalence, how common it is way higher in places like the Middle East, Asia, the Mediterranean, and Eastern Europe.
Okay.
But then it's quite rare in Africa, Western Europe, and North America.
Do we have numbers on that?
Yeah, for perspective, North America is maybe around 0.75% prevalence, but Eastern Europe, it could be anywhere from 3% up to, well, the striking 39% in some studies.
Wow, that's a huge difference.
It is. And there was that old incorrect idea that it was mainly a disease affecting Jewish people, which our sources clearly state is not true.
Right. Important to debunk those myths. And that gender shift is significant, too. Sources say women can now make up nearly a third of patients in some studies.
Up to 30%, yeah, though men are still affected maybe 4 to 10 times more often.
Interesting. But the overall number of new cases seems to be going down in some places, like the Mayo Clinic in Japan.
That's been observed, yes. The ratio of TAO patients compared to those with standard atherosclerotic disease has decreased quite a bit in those areas.
Any idea why?
It could be a few things. Changes in smoking habits, maybe? Or perhaps better diagnostics, meaning fewer misclassifications of other conditions as TAO?
Makes sense. So Current estimates,
Hmm.
maybe 10 per 100,000 in the EU, around 4,000 people in Japan.
Those are the ballpark figures, yes.
Okay, let's get to the big one, the elephant in the room, maybe. What actually causes TAO? The sources seem pretty united on one thing.
Overwhelmingly so. The single risk factor that comes up again and again consistently is smoking. Tobacco use. Any kind.
Any kind.
Any kind. The link between tobacco and both starting this disease and making it worse is just undeniable. It's the cornerstone.
And it's not just cigarettes, is it? I was struck by the range mentioned cigars, pipes.
Oh, yeah. And even really specific local forms like bidi smoking in South Asia, kawang in Indonesia, chewing miang, or kio in Thailand.
Even cannabis mixed with tobacco.
That's been reported, yeah, in France, for instance. And definitely includes smokeless tobacco and marijuana use, too.
So it really points to something in the tobacco itself, doesn't it? Regardless of how you use it.
That's the strong implication. Now, beyond tobacco, other things have been suggested as maybe contributing factors.
Yeah.
Lower socioeconomic status, poor dental hygiene,
Right.
nutritional issues, maybe past viral or fungal infections, cold exposure, abusing certain stimulant drugs, and even arsenic exposure.
Arsenic, that seems out of
Sure.
left field.
It does. But there's this condition in Taiwan called Blackfoot disease, linked to arsenic in drinking water, that has some similarities. So some researchers wonder if arsenic contamination in tobacco could be a factor in certain places.
Huh. Interesting.
And we're also seeing more links between ischemia, that reduced blood flow that looks a lot like TAO in people addicted to cocaine, amphetamines, cannabis, suggesting maybe those drugs can mimic TAO or speed it up if someone's susceptible.
So the exact mechanism is still a bit murky, but the tobacco connection is crystal clear.
Absolutely.
But the sources do try to dig into how tobacco might be causing this, right? The biology behind it.
They do. Several potential mechanisms are being looked at. A leading theory involved the immune system, basically an immune-mediated injury.
Okay, the body attacking itself, triggered by tobacco.
That's the idea. There's evidence for it. For one, active smoking, you can measure high cotinine levels, that's a nicotine byproduct, directly correlates with TAO getting worse.
Right.
And studies show TAO patient cells are more sensitive to collagen, those proteins in blood vessel walls, compared to other people. Plus, finding these circulating immune complexes in the arteries of some patients points towards an immune reaction happening right there in the vessels.
So the theory is something in the tobacco smoke triggers this immune attack on the vessel lining.
That's the prevailing thought. Some unidentified component sets it off. And it gets pretty specific at the cellular level. T cells, B cells are involved.
As soldiers of the immune system.
Exactly. Recent research points to T cell and B cell immunity being key, plus activation of other immune cells like macrophages and dendritic cells right in the intima, that inner layer of the artery.
Okay.
This activation leads to inflammation. You see more activation of the endothelial cells lining the vessel, more TNF-alpha, that's a major inflammatory signal, and more adhesion molecules. Think of those like Velcro on the vessel wall, grabbing immune cells.
So the immune system essentially gets called into the vessel wall and starts causing trouble because of the tobacco trigger.
A good way to put it. And researchers find higher levels of pro-inflammatory signals, cytokines like IL-1 beta, IL-6, IL-17, and lower levels of the anti-inflammatory ones like IL-10. It really suggests an autoimmune process.
An imbalance.
Yes. There's even experimental work on a protein called HMGB1. It seems to promote inflammation and clotting in TAO models, and blocking it helped. Clinical studies then confirmed higher levels of HMGB1 and related inflammatory markers in TAO patients.
And all this inflammation is what ultimately causes the blockages, the occlusion.
That's the belief. It drives the clot formation and vessel narrowing. Interestingly, there's also some overlap seen with antiphospholipid syndrome, another clotting disorder, and more anticardiolipin antibodies found in TAO patients. That might mean earlier onset, more amputations, maybe a tougher prognosis. Some studies mention other autoantibodies too, like ANCAs, but the findings there are a bit inconsistent.
So a strong immune connection. What about genetics? Could some people just be genetically wired to react badly to tobacco this way?
There's definitely evidence suggesting a genetic susceptibility might be part of the picture.
Like what?
Well, you see reports of families in Japan with multiple members affected by TAO, and studies link TAO to specific HLA types, those immune system markers in different countries.
Okay.
The current thinking is maybe the artery spasms, the vasospasm, common in TAO, result from smoking interacting with gene variations that reduce nitric oxide, that vessel-relaxing molecule.
Ah, right.
Some studies found more mutations linked to vasospasm or specific tiny genetic variations called SNPs in certain groups like the Uyghur population.
Yeah.
But, we really need larger studies to nail down the genetic links firmly.
So immune system, genetics. What about just general blood clotting? Are people with TAO just more prone to clots overall?
That's still a bit debated, actually. Most researchers haven't found a consistent, specific hypercoagulable state in TAO patients, but some studies have reported certain clotting abnormalities, so it's not as clear-cut as the immune angle or the potential genetic factors.
Okay. Now here's one that surprised me a bit. Reading the sources, a potential link to oral health. Gum disease.
Yeah, it's interesting, isn't it? Buerger himself suspected infections might play a role way back. And now we have solid evidence showing people with TAO are much more likely to have severe gum disease, periodontal disease.
Really? How strong is that link?
Pretty strong. Studies have found higher levels of antibodies against specific mouth bacteria in TAO patients, and even bacterial DNA from those gum bugs has been found in tissue samples from their blocked arteries and inflamed veins.
Wow. So inflammation in the gums could somehow be contributing to inflammation in the blood vessels elsewhere.
It's a pathway researchers are definitely looking into. Then there's another angle, maybe even more unexpected, rickettsia.
Rickettsia, like the bacteria causing Rocky Mountain spotted fever and typhus?
The very same. Some early researchers actually proposed rickettsia infection as the main cause after finding antibodies in TAO patients.
Yes.
Yeah. And more recently, studies have detected rickettsia DNA and antibodies in some TAO patients too. So it's led to this hypothesis that maybe rickettsia infection is another piece of this very complex puzzle.
That's definitely a twist. Okay, and lastly, the sources mention something about the health of the vessel lining itself, the endothelium, and the circulating progenitor cells, repair cells.
Right. Even in limbs that don't seem obviously affected in TAO patients, the endothelium doesn't work quite right. The vessels don't relax properly. And during flare-ups, the baseline tone in the larger arteries increases, squeezing blood flow even more. It's interesting, though, while vessel dilation is impaired, similar to atherosclerosis, the number and function of those circulating progenitor cells, the repair crew, seem to be okay, despite the endothelial problems.
There's more vasoconstriction happening too.
Yes, levels of endothelin-1, a potent vessel constrictor, are higher during flare-ups, so there's a really complex mix of factors going wrong.
Okay, incredibly complex. Let's shift now to what this actually looks like down at the tissue level. What are the hallmarks of TAO pathology?
So the exact mechanisms are still being figured out, but the key features are inflammation within the vessel wall, segments, arteries, and veins, and blood clots forming inside them, occluding them.
Okay.
Importantly, these clots, these thrombi, are very cellular, packed with inflammatory cells, but the basic structure of the vessel wall itself, that stays mostly intact.
Ah, okay. So unlike some other vasculitis types where the wall gets destroyed.
Correct. That's a key distinction. The understanding has shifted, actually. It used to be seen as mainly a clotting problem causing inflammation secondarily. Now, it's viewed more as a primary inflammation of the vessel wall leading to the clots.
Got it.
The idea is something, maybe those tobacco glycoproteins, damages the endothelial lining. This activates immune cells, which kick off both cell-based and antibody-based inflammation.
And this happens mostly in the inner layer, the intima.
Primarily, yes. That's why it's often called an endarteritis. That intimal inflammation, followed by T cells moving in, seems to be the key event, causing the early artery blockages that are so characteristic of TAO.
And the sources describe 3 stages based on the pathology: acute, intermediate, chronic.
Exactly. In the acute phase, you see active inflammation in those small and medium vessels. You get this occlusive clot full of cells, different types of white blood cells, even giant cells. You can even see tiny pockets of pus, microabscesses.
Yikes!
Yeah. And the inflammation is intense, involving the whole vessel wall, but especially the intima, and often spreading to the nerves and tissues right around it, the neurovascular bundle. Very inflamed. Lots of cell growth, especially in the veins.
Okay, then it moves to the intermediate phase.
Right, the intermediate or subacute phase. Here, the body starts organizing that clot, breaking it down, sometimes creating little channels through it, partial recanalization. The microabscesses go away.
But the inflammation is still there.
Oh, yes. The immune response continues. You see T cells, B cells targeting the internal elastic lamina, that elastic layer in the vessel wall. Macrophages, dendritic cells are still present in the intima. And you find deposits of antibodies and complement proteins, too.
And the final stage, chronic.
The chronic or end stage. This involves more clot organization, more recanalization, hopefully, new blood vessel growth within the middle layer of the wall, the media, and scarring, fibrosis. around the vessel.
But the key point through all this.
The key point is that the internal elastic lamina and the overall architecture of the vessel wall remain surprisingly well preserved. That's really what sets TAO apart histologically from atherosclerosis, where the wall degenerates, and from many other systemic vasculitides where the wall structure gets much more damaged.
That's a critical distinction for diagnosis. So, okay, how do these microscopic changes translate into what a patient actually feels or experiences? What are the classic signs and symptoms?
Typically, TAO shows up as ischemia, not enough blood flow in the hands, feet, lower legs, lower arms, usually in a smoker under 50. The average age at diagnosis is actually around 34.
And it often starts with specific kinds of pain, doesn't it? Like in the feet.
Yes, very characteristic is claudication, but specifically in the arch of the foot or the lower calf. Pain with walking, relieved by rest. Foot claudication is a big clue.
Sometimes mistaken for just foot problems.
Easily done. Other early signs can be just persistent coldness or a burning pain in the feet or hands. You might see the limb turn reddish when hanging down dependent rubor or bluish from lack of oxygen cyanosis, and that migrating superficial thrombophlebitis we mentioned.
The vein inflammation that moves around.
Exactly. Raynaud's phenomenon is also common, fingers and toes changing color with cold or stress.
Cold sensitivity seems like a major complaint.
Huge. And sensory changes, numbness, tingling can be really early signs. One study found almost 70% of patients had those. The pain can be severe too, either from nerve ischemia or the phlebitis itself.
And that migrating phlebitis is a pretty strong indicator early on.
It really is. Seen in maybe 40 to 65% of patients as an early sign. Sometimes it can even involve deeper veins, though true DVT is less common in Buerger's. And in the acute phase, those affected vessels can be tender, feel firm, or thickened.
And if it progresses, the consequences get much worse.
They can, yes. Later on, you might see changes in the nails, ischemic ulcers, sores from lack of blood flow, and eventually digital gangrene, tissue death in fingers or toes, usually in people aged 20 to 50.
And those ulcers sound particularly nasty.
They can be. Often get infected, become excruciatingly painful, typically look dry, irregular borders, pale base. Interestingly, some people, maybe 12–13%, get temporary joint pain, like in the wrists or knees, before the finger or toe problems really start. You might also see tiny splinter hemorrhages under the nails. And we shouldn't forget the psychological toll. Anxiety, depression are common, understandably, with chronic pain and the fear of amputation or losing work.
And it usually hits more than one limb, right? Not just isolated to one foot or hand.
That's very typical, yes. Multiple limb involvement is the norm. One big study found only 16% had just 2 limbs affected, 41% had 3, and 43% had all 4.
Wow. So checking all 4 limbs is essential.
Absolutely essential if you suspect TAO. And while it's rare, TAO can sometimes affect internal organs, brain, heart, gut, even arteries like the internal thoracic, leading to all sorts of potential issues, from cognitive problems to heart attacks or bowel ischemia.
Goodness.
Extremely rare reports even mention it in bypass grafts, head arteries, eye circulation, kidney arteries. Basically, if you see the classic TAO pathology in an unusual spot, along with the right clinical picture, it can still be TAO.
Given this huge range of possibilities, how on earth do doctors actually diagnose TAO? Sounds like a real puzzle.
It definitely can be a challenge. A big part of that is there aren't, universally agreed upon strict diagnostic criteria. Several sets have been proposed over the years. Shanoya's, Papa's scoring system, Mills and Porter's criteria, Allen's criteria.
Different approaches.
Different focuses, yeah. But the one thing they all agree on is you have to rule out other causes of artery disease, especially atherosclerosis, apart from the smoking link.
So it starts with a really careful history and physical exam.
Absolutely paramount. A full vascular exam, checking pulses everywhere. Often the big pulses in the arms and legs are fine, but distal ones, radial, ulnar, foot pulses are weak or gone. Digital arteries might be blocked.
The Allen test for hand circulation?
Often abnormal, yeah. Suggests ulnar artery occlusion, especially if you see it in a young smoker with leg ulcers. That finding pops up a lot. Seeing superficial phlebitis is another clue. And checking for nerve involvement, those sensory changes.
And then simple non-invasive tests, like blood pressure cuffs on the limbs.
Right. Ankle brachial index, ABI, toe brachial index, TBI, wrist brachial index. Measured at rest and after exercise. Segmental pressures are usually normal higher up the limb, but drop off significantly further down. Digital plethysmography, measuring finger and toe blood flow, will usually be abnormal in both arms and legs. And a key finding on plain x-rays. Usually no calcification in the arteries, unlike atherosclerosis.
What about ultrasound?
Arterial duplex ultrasound is really useful. It helps rule out proximal atherosclerosis, shows the distal blockages, and critically, it can often visualize those characteristic corkscrew collateral vessels, Martorell's sign.
The body trying to bypass the blockages?
Exactly. They look like little snakes or dots on the ultrasound. These findings suggest the inner lining, the endothelium, is selectively impaired, but maybe not the smooth muscle itself. Newer ultrasound tech might see these collaterals even better, and things like laser, Doppler, or transcutaneous oxygen measurements can help gauge how bad the ischemia is and track treatment response.
And ruling out other causes is a big part of this too, right? Like clots traveling from the heart.
Crucial. You have to exclude emboli. So cardiac workup is standard ECG, maybe heart rhythm monitoring, and echocardiogram, sometimes an abdominal ultrasound to check the aorta.
What about more advanced imaging like MRA or CTA?
Yep. Gadolinium-enhanced MRA and multi-detector CTA are good alternatives for visualizing the vessels. And if there are ulcers that might be infected, regular X-rays or MRI can check for bone infection, osteomyelitis. Peaky scans, though. Turns out they're not very helpful for diagnosing TAO.
Are there any specific blood tests for TAO?
Sadly, no single blood test says, yes, it's TAO. Lab tests are mainly used to screen for other things, autoimmune conditions, clotting disorders, other types of vasculitis.
Okay.
General inflammation markers like ESR and CRP are often normal or only slightly up, unless there's major tissue damage. You typically don't see the high levels of autoimmune markers found in other conditions, though, as we mentioned, anticardiolipin antibodies might pop up. And toxicology screen for drugs is definitely recommended.
And angiography injecting dye to see the arteries, that's still important.
Still plays a really key role, yes, both for supporting the TAO diagnosis and ruling out other things. The findings on an angiogram can be very suggestive, but maybe not 100% specific on their own.
What are those classic angiogram findings?
You look for segmental blockages, blocked bits, alternating with normal-looking bits. Disease is usually worse distally, in the fingers and toes. Proximal arteries look normal, no atherosclerosis. And then you see those collaterals, the corkscrew, tree root, or spider leg appearance.
Martorell's sign again.
That's the one. Usually involves arteries below the knee and elbow most often. Smaller corkscrews might mean a higher risk of ulcers. But remember, corkscrews aren't only seen in TAO. You can see them in connective tissue diseases or with drug use too. It's the whole pattern that points towards TAO.
What about a biopsy? Taking a tissue sample, is that commonly done?
Not usually needed if the clinical picture and imaging fit well. It's more reserved for atypical cases. Maybe if the onset is over 45 or there's proximal disease or weird nodules or diabetes or CNS signs or positive autoimmune markers.
Okay.
However, if someone has acute superficial thrombophlebitis, biopsying that inflamed vein can sometimes show the classic TAO changes and help confirm things.
So when trying to diagnose TAO, what are the main things doctors need to differentiate it from? What's on the differential list?
Oh, it's a long list. You've got your standard atherosclerotic disease, ASO, blood clots traveling from elsewhere, thromboembolism, and then a whole host of other vasculitides.
How do you tell them apart?
Key differences from ASO are the distal pattern in TAO, the migrating phlebitis, the younger age. Compared to other vasculitides, TAO usually doesn't have tissue death or granulomas in the vessel wall. The structure is better preserved, and those autoimmune blood tests are usually normal.
Specific conditions to consider.
Things like scleroderma, Crest syndrome, lupus, SLE, Takayasu arteritis, polyarteritis nodosa, giant cell arteritis, rheumatoid vasculitis, antiphospholipid syndrome, vascular compression syndromes, even malignancies or blood clotting disorders, drug reactions, ergot use, cannabis arteritis infection. Yeah. If it's really tough to tell, especially between TAO and ASO or another vasculitis, sometimes that biopsy of a nodule or vein can be the tiebreaker. The key histological clues for TAO remain that inflammatory clot, relative sparing of the vessel wall, and the preserved internal elastic lamina. There's even a rare thing called Kimura disease that can mimic TAO symptoms sometimes.
So diagnosis is really about putting all the pieces together, the story, the exam, the tests, ruling things out, maybe sometimes looking at the tissue. Okay, let's talk about the natural course. What happens over time with TAO?
It's characteristically waxes and wanes, periods of flare-ups, exacerbations, then periods of remission where things might calm down. One study found patients had, on average, about 5 flare-ups over about 10 years.
And quality of life takes a hit?
Significantly diminished, yes. Chronic pain, disability. Life expectancy findings are a bit mixed. One study said it was comparable to the general population. Another found it significantly lower, average age of death around 52.
And the risk of amputation, that's the big fear, isn't it?
It's substantial. and it increases over time. One study put the risk of any amputation at 25% by 5 years, 38% for 10 years, almost half 36% by 20 years.
That's sobering. What about major amputation, like above the ankle or wrist?
Same study found that risk was 11% at 5 years, 21% at 10, 23% at 20 years. But, and this is critical, that major amputation risk was dramatically lower in people who stopped smoking, basically eliminated after 8 years of quitting.
That's a powerful statistic for quitting.
It really is. Other studies show similar survival rates overall, and often the really bad tissue damage, the necrosis, tends to slow down or stop after age 60. But the message is consistent across the board. Continuing to smoke is strongly linked to more amputations, worse quality of life, losing your job.
A large French study also found non-white ethnicity and having a limb infection when diagnosed were independent risk factors for worse outcomes.
That's right. So yeah, the bottom line on natural history, it's tough. Marked by flare-ups, risk of limb loss is real, but quitting smoking makes a massive difference.
Which leads us directly into treatment. Given everything we've said, what's the absolute #1 priority?
Smoking cessation. Complete, permanent. No ifs, ands, or buts. Any form of tobacco, including passive smoke exposure.
And it doesn't matter how much you smoke or what kind?
Doesn't seem to. The hazard appears independent of the number of cigarettes, type of product, how you smoke it. Quitting is paramount. Counseling, support programs, medications like bupropion or varenicline are key. Exercise helps too.
But not nicotine replacement, like patches or gum.
Generally avoided, yeah.
Okay.
Nicotine itself constricts blood vessels, so it could potentially make TAO worse. And it's important to manage expectations. Even quitting, while vital, might not be enough on its own to save a limb if someone already has critical limb ischemia.
Okay. Exercise is also really important, you mentioned.
Definitely. Regular exercise training helped a lot with claudication. Pain improves how far people can walk without pain and their maximum distance. There are specific exercises too, like Buerger-Allen or Rapshow's exercises involving limb positions that might help with critical limb ischemia.
Right.
An ischemic exercise might even help release those progenitor repair cells. Major guidelines actually give supervised exercise a top recommendation for improving claudication symptoms, and that applies here too.
Beyond quitting smoking and exercising, what other basic lifestyle things help?
Simple stuff, but crucial for preventing ulcers. Meticulous foot and hand hygiene daily. Avoiding any trauma, thermal injury, hot or cold vibration, chemicals, tight shoes. Treat any injury immediately, aggressively.
And maybe good dental care too, given that potential link.
Makes sense, right? Good oral hygiene, treating gum disease, might offer some benefit.
Okay, what about medications? Are there drugs that specifically treat TAO?
Well, treatment is very tailored. Lots of drugs get used antiplatelets like aspirin, clopidogrel, sometimes anticoagulants, drugs trying to improve blood flow like pentoxifylline, NSAIDs for pain, even immunosuppressants in severe cases.
But the evidence for many of these isn't super strong for TAO specifically.
Exactly. There's a real lack of big, high-quality randomized trials for many common agents in TAO. Steroids are controversial. Just isolated reports suggest they might help some people with high eosinophils. Of course, you treat infections with antibiotics, use NSAIDs for phlebitis pain.
What about for Raynaud's symptoms?
Calcium channel blockers, nifedipine, amlodipine, they can help reduce the frequency of those attacks. Higher doses might work better.
The sources seemed more positive about prostacyclin analogs, like elaprost.
Yes, that's one area with better evidence, particularly intravenous elaprost for critical limb ischemia. It helps dilate vessels and stop platelets clumping.
How good is the evidence?
Moderate quality from limited trials, but a big European trial showed IV elaprost was better than aspirin for healing ulcers, relieving pain, and reducing amputations over 6 months. A Turkish study found it better than lumbar sympathectomy surgery for healing ulcers.
And combining it with quitting smoking is even better.
Significantly reduced amputation risk, yeah. So based on the evidence, including a Cochrane review, IV elaprost is considered an effective option for ulcers and rest pain in TAO patients with critical limb ischemia.
But oral elaprost, not so much.
Right. One trial showed it helped rest pain a bit better than placebo, but didn't heal lesions significantly. A meta-analysis confirmed it wasn't really more effective than placebo overall. Another similar drug, limaprost, used in Japan, didn't beat an antiplatelet drug in one trial.
Okay. What about PDE inhibitors, like silostol?
Silsols, a PDE3 inhibitor, has shown some promise. It dilates vessels, has antiplatelet effects. A small study showed ulcer improvement. One trial found adding it to IV elaprost improved symptoms and quality of life in critical limb ischemia better than elaprost alone. A recent study suggested it reduces inflammatory markers too. Solstitol is well established for improving walking distance and standard claudication, so that might help TAO symptoms too.
And PDE5 inhibitors like sildenafil.
Fewer studies, but some case reports suggest drugs like sildenafil or tadalafil might help digital symptoms, probably through vasodilation. Also, endothelin receptor antagonists like bosentan blocking that vasoconstrictor have shown encouraging results in case series and one prospective study improving ulcers and pain. But again, need bigger trials.
What about clot-busting drugs, thrombolytics?
They've been tried, sometimes infused directly into the artery, but results are mixed. Limited limb salvage in some series, bleeding complications. One report showed it didn't even open the artery, so yeah, need better trials there too.
Any other medications? Folate? Statins?
Folate was tried in patients with high homocysteine. It lowered the homocysteine but didn't affect amputation rates. Very low certainty on statins. Well, they have anti-inflammatory effects and help endothelial function, which sounds good, but their role in this kind of inflammation-driven thrombosis isn't clear yet. Needs more research.
Pain management is obviously huge.
Absolutely essential. Opioids, NSAIDs, sometimes antidepressants for nerve pain, even nerve blocks might be needed. Regional sympathetic blocks, like a Beer's block with quinephrine, have shown promise in reports, but have limitations. And spinal cord stimulation is being used. More helps with pain, might improve microcirculation, an option when other things fail.
So, lots of medical approaches. What about actual surgery?
Lumbar or thoracic sympathectomy, cutting those sympathetic nerves, used to be more common. But that Turkish trial found Vanvit Ilapros healed ulcers better. Minimally invasive sympathectomy is still sometimes done, especially for upper limbs.
What about bypass surgery, creating detours around the blockages?
That's tricky in TAO. The disease is often so widespread and affects such small distal arteries. Finding a good artery to bypass to and having a good quality vein to use as the graft could be major challenges.
So it's not often an option.
It's less often suitable than in atherosclerosis. But in select patients with critical limb ischemia and a usable distal artery, bypass with their own vein is considered. Success rates vary. Some studies show okay patency, especially if patients quit smoking. Others show limited long-term success. It's complex, depends on many factors. Different techniques exist, even bypassing to collateral vessels. Sometimes local flaps are needed to cover ulcers after a bypass.
Are there other, less common surgical options for really bad cases?
Yes. A pedicled omental graft, bringing fatty tissue with its blood supply from the abdomen down to the foot, has been used, particularly in India, reportedly with good results for saving feet. Not common elsewhere, though. And distal venous arterialization, basically turning a vein into an artery bypass, is a complex last resort when no arteries are suitable for grafting. Meta-analysis shows decent one-year foot preservation rates with it.
And of course, basic wound care for those ulcers is vital.
Absolutely critical. Careful cleaning, debridement, removing dead tissue but not too aggressively, appropriate antibiotics for infection. Topical agents can help. Hyperbaric oxygen, maybe in select refractory cases, but evidence isn't strong and it's expensive. Negative pressure wound therapy can be useful for complex chronic ulcers.
What about endovascular treatments, going inside the vessels with wires and balloons? Angioplasty.
That's being used more too. Percutaneous subintimal angioplasty, basically tunneling through the blockage, is tried for limb salvage. Some studies report good technical success opening up tibial and foot arteries. Atherectomy devices that remove plaque have been tried too, but need more data.
Comparing endovascular to bypass.
One Chinese study suggested endovascular might give similar amputation-free survival, even without great runoff vessels. A Korean study showed decent 3-year outcomes after endovascular therapy, so it's definitely an option being explored.
Okay, finally, the sources mention some really cutting-edge, almost experimental interventional things.
Right, still mostly investigational. Immunoadsorption filtering antibodies out of the blood showed promise in pilot studies for pain relief and perfusion, based on the idea of removing problematic autoantibodies.
Growth factors, gene therapy.
Using growth factors like VEGF to stimulate new blood vessel growth, angiogenesis is being tested. A phase 1 VEGF gene transfer trial showed some ulcer healing and pain relief. Another trial with a different vector also showed safety and potential benefit.
And stem cells. Therapeutic angiogenesis.
That's a big area of research. The idea is implanting the patient's own stem cells from bone marrow, peripheral blood, fat tissue into the ischemic limb to encourage new vessel growth and repair.
Any success there?
Some promising results in studies. Improved pain, walking time, quality of life reported after injecting bone marrow mononuclear cells. High amputation-free rates at 10 years in one study. Meta-analyses suggest a potential benefit. Some trials show long-term improvement. Different delivery methods are being tried.
But the overall evidence quality.
A Cochrane review recently called the evidence for stem cells very low quality still. So, promising, but needs more robust research. There's even a technique involving wires in the bone marrow, tibial fenestration, suggested to stimulate angiogenesis, possibly by mobilizing progenitor cells. But we also know those progenitor cells might not function properly in TAO patients. So lots of ongoing work to understand how best to promote new blood vessel growth.
Truly remarkable, the range of things being tried, from the absolute basics to these highly advanced therapies. As we wrap up this deep dive on thromboangiitis obliterans, what's the single most important takeaway message for our listeners?
It has to be the smoking cessation. Complete, lifelong quitting. That is, without doubt, the most critical factor for managing TAO, for potentially stopping its progression and dramatically cutting the risk of amputation. Everything else, while important for symptoms and quality of life, really revolves around that central point.
In reflecting on everything we covered, was there one thing you found particularly surprising or intriguing about TAO?
I think the sheer geographical variation in how common it is, that really jumps out.
Wow.
It strongly suggests there might be other environmental factors or maybe specific genetic vulnerabilities in certain populations playing a bigger role than we fully grasp yet. And also, just the complexity of the immune response involved. It's fascinating how research keeps uncovering more layers.
It absolutely highlights how complex vascular health is and just how profoundly lifestyle choices, especially smoking, impact it. If you, listening, know someone affected by similar issues or you're just interested in learning more about vascular diseases, definitely explore the research we talked about, maybe discuss it with healthcare professionals.
Yeah, and it leaves you thinking, doesn't it? Given this incredibly strong link to tobacco, what does the fact that TAO is more common in certain parts of the world tell us about global health patterns and maybe the ongoing struggle against tobacco use worldwide? And looking forward, with all the research into stem cells and immunotherapies, what breakthroughs might be on the horizon for people living with conditions like Buerger's disease?